right, so welcome this morning at the first TV studio session here in Helsinki at the ESOC conference. And I'm happy that we can talk about a very important topic, I think, and still a controversial topic in endovascular treatment of acute ischemic stroke. And that is the use of a balloon guide. I know that there are physicians that really like to use it always. There are physicians that use it once in a while, and there are physicians that say you should never use it. So let's have a discussion about this, why we think, the three of us here, and let me introduce you then, Tobias Buch-Berends and Maria Bernmuck, both from the Technical University in Munich, both neurointerventionalists, and they will talk about the use of a balloon guide, maybe convince you to use a balloon guide, but at least show the advantages of using a balloon guide, and especially the newer generation balloon guides that we are going to talk about. We start with a kind of introduction about what is a balloon guide, how do we use it, and that will be done by Tobias, and then we will discuss some cases with Maria. She has prepared some cases, and we'll see how you will think finally what is the benefit of using a balloon guide. So Tobias, I leave it to you to start the introduction, and in the meantime we will see how we get to the cases and what the evidence is.
So, thank you, Wim. Thank you very much. And exactly, I will just start with a very short explanation of the basic principle of the using a balloon guide. This is a short movie where you can see that when you have a clot in the distal vessel, and then you use a stent retriever, you have a balloon guider in the ICA, and then you inflate the balloon, you get the flow arrested. And if you then withdraw the clot inside the stent retriever, this is the point where you can achieve a flow reversal through the balloon guider. And if some fragments occur, this is exactly the moment when you open up the balloon guider or you do not have one, then these fragments will go upwards and produce exactly something like this, what is shown here in this case, where you have an M1 occlusion successfully reperfused, and you see in the control run that there's a new occlusion which has not been there before, which we call an ENT, so an embolization to new territories. And this is exactly what we really want to prevent with these kind of devices. And regarding the evidence that you mentioned, we have actually a lot of evidence. This is a review where you can see that nearly in all really important points like TICI, so successful reperfusion, also the MRS variables, so outcome data, they all show a benefit of using a balloon guiding catheter, and this is also true for the different techniques that we can use, like stent retriever alone or a combination technique. And of course, all these studies that we see here are not randomized, but also some of them are registries, so large, also prospective registries. So the evidence is not really high at this point, and
but these are all done with the first generation balloon guides, isn't it?
Exactly.
The ones you show here.
Yes, exactly. Yeah. All the evidence actually that we have, nearly all the evidence, is was achieved by for the older generation balloon guiders. And then after these retrospective studies, and we have now 2 randomized trials, one of them from China, one of them from the UK. And the interesting thing is that these 2 trials show a complete different image. So you see on the left side there are the outcome data from the Chinese study, and on the right side from the UK study. And especially in the MRS variables from 3 to 6, you see the difference is it's completely the opposite what you see in these 2 trials. And also, if you look at the secondary endpoints, like the things that we want to prevent by using the balloon, like the ENTs. In the UK study, it was positive, and not in the Chinese study. The symptomatic hemorrhages were lower in the UK study in ProFate and higher in PROTECT-MT. The same is true for the mortality and also the success rates that we saw.
Yeah, most important thing I think in the first line that what you want to prevent ENTs is clearly shown in the British study, where there was a percentage of ENTs of 12% in the control group, so with a conventional guide catheter, and they could reduce it with a balloon guide to less than 1.5%. And you don't see. First, in the control group in the Chinese arm, it's only 4%, so that is different. And it didn't change when they used the balloon guide. And for the other outcomes, of course, they are secondary, more or less, to the first outcome. It's a surprise. Do you have an explanation why there's such a difference between the outcomes in those two trials?
Well, actually, I think it's difficult because the study itself, it's published in Lancet, so it's a good designed study if you look at it in the first place. But it's the only study that we have that is completely contradictory to every evidence that we have, not only to the other randomized trial.
The Chinese is also contradictory to the old evidence that we had from
exactly.
the yeah.
And what I think is one of the main points why we can explain these different results is an aspect that we will discuss later. It's the influence of the tip position of the balloon guiding catheter, which was in the guidelines of the PROTECT-MT trial. They just recommended to use the balloon guider in the low cervical position.
So it was recommended even in the trial itself to place it in a proximal position and not distal. And for the
conventional guiding catheters, it was recommended to place it as
distal,
as distally as possible. So this is one of the possible explanations. Another thing is, of course, if you're used to use these kind of devices, then you have a learning curve, like in everything.
Yeah. So do we have an indication that in the Chinese group, the physicians were not used to use a balloon guide, and that they had to do it here in this trial?
It is not published, so we cannot see it from the also not in the supplemental things that we have. But they were experienced interventionalists. That is shown in the data. Yeah. But not how many or how they are used to the balloon guiding catheters.
No. So placing the tip very distal might have been of influence in the outcome, in especially the Chinese study where they didn't place it very distal. And that maybe is because they used all the generations, which are stiffer and not so easily guiding up to the distal position.
Exactly. I think this is one of the major points where the newer generation of guiding catheters really change a lot. And as I said, this is the level of evidence that we have now. So there are recommendations to use these, but it is, as I showed, it's really in discussion.
Yeah, and with the two new studies that are so contradictory in their outcome, we cannot really update the evidence. I mean, there's still not convincing evidence.
Absolutely. And now, if we're talking about the newer generations, then the only evidence that we had was this one for the Walrus. So the newer generations are, at least in Europe, which is available, is the Walrus and the EmboGuard and the Bobby. All these three are completely different to the older generation devices. And So we have this retrospective study from the walrus which showed quite good results, and now we have another study performed evaluating prospectively the Bobby guiding catheter, which is this one, and which is obviously completely different to the older generation devices. And what you can do with these kind of catheters can be shown by also by an example.
Yeah, so Maria, you had an example of how you can use the newer generation and how it is possible to bring it to a more distal position than with the older, stiffer ones.
So here I have a case. It's an 85-old woman, came with a right-sided carotid T occlusion. She was highly affected with the right hemispheric syndrome. And then you make the first run and see that kind of atrial access. It's very challenging, as you might know. So I want to show you how we made that. We had a short sheath, we had the balloon guide catheter, the Bobby in between, and then we had the diagnostic catheter. We used a SIM to get the wire up. And then, as you can hear in the video, the SIM catheter stucks there. It does not go further. And then what you do, you take the balloon catheter and it follows very smooth. The old ones, the conventional catheters and all the old generation balloon guiding catheters would not do that so smooth. So it's one characteristic of the new generation catheter, and then it follows the catheter, but it does not go further. Then you inflate the balloon and you use the balloon as a sail. It's like a kite that uses the wind to go up. Here you can use a balloon to go up with the bloodstream and generates the stability to get the diagnostic catheter more up. Then you deflate the balloon again and follow the diagnostic catheter.
So in this case, you inflate the balloon to let it go with the flow, or did you also inflate it to have a more strong anchor to bring up the diagnostic catheter?
That I wanted to say, that's the second thing you can do. In this case, it was not necessary to inflate it so much that it stuck in the vessel. This is the second thing we do if this we have success with that. Then we use it as an anchor, that we then have the pressure to get the other devices up.
So here you let it flow.
We'll let it flow like the kite flies in the wind.
Okay, great. Yeah.
So nice before we go further on this case, let's go back to the evidence we have for the new generation balloon guiding catheter.
Yeah, just very briefly talking about the STRAIT study, which I mentioned before, which is this prospective evaluation of the Bobby. It was a multi-center trial in several centers in Germany and Switzerland, and we enrolled about 170 patients. The primary endpoint was a technical one, was the successful reperfusion, but we had a very close look at a lot of secondary endpoints, looking at the performance characteristics, but also safety, of course, and procedural and outcome data. So the population is quite standard, nothing special. The occlusions that were treated are mainly M1 and M2 occlusions, only a small subset of ICA occlusions. And now coming directly to the primary endpoint. So the successful reperfusion was 95%. Which is exactly the number of the retrospective walrus study, and very high. But these are data that are core lab controlled and prospective, so have another quality, I think. And the first pass effect is also nearly identical, very high with 63%. Outcome data also very good, more than 60%. Independent outcome and quite low mortality rate. So these are the basic evaluations or data from this prospective trial, which is not yet published, but will be soon. And then we had really a closer look also at technical details in this study. And the first thing is that we looked how good is it possible to place these kind of catheters in the distal position, what we talked about before, and this was quite good in 2/3 of the patients, we could place it at least in the mid-segmental part of the ICA.
So in the trial, it was registered how distal, the place where you positioned the balloon guide in the carotid artery. Because in the older, and on the older trials and the evidence that you showed, we had no idea. Usually they placed it very proximal because it was not possible. So it's good to see that you recorded the position of the balloon guide in this trial, because I think that's one of the main things, the most important factor for the success.
Yeah, we planned that from the beginning because you have to also have the images where you can see this. So yes, this was one important endpoint for the study, and of course it is dependent on the anatomy, obviously. And maybe regarding that point, Maria can continue with the case from.
So I show you how to get the catheter up. Let's go back to the carotid T occlusion from before. So we have brought the balloon guiding catheter in the proximal part of the ICA. And now here you can see the angle. That's a very small angle and very tortuous vessel. And with the conventional navigation techniques, it may not be possible to bring the catheter more up. So I can show you one trick you may know from the aspiration maneuvers. So you bring the stent retriever through the thrombus, expand the stent retriever, and then use the stent retriever as an anchor. You pull on the wire of the stent retriever, and then you can straighten the vessel, as you can see here in the video. And then you can bring up your balloon guiding catheter to the point of the skull base. You see here it walks up very easily when the vessel is straightened, and then reaching that point, it's a correct place to open the balloon for the maneuver. So we did the maneuver with a combination technique, aspiration, stent retriever, and also the proximal flow arrest at this point, at the skull base. It worked very well. But if you have to do second or third maneuvers, then you have brought the balloon guiding catheter at the right place with this maneuver, but you have to care about that. You have to keep an eye on the balloon, because when you pull on your wire, sometimes it goes up. That's not good. If the balloon is inflated, you may cause these dissections. And also, if you pull the stent retriever completely out, sometimes you lose your position, your high position. So you have to care about when making the maneuver.
Yeah, so if you take out the stent retriever through the balloon guide, you keep a hand on the balloon guide to pull it back.
Always.
If it's going up?
Always.
So keep control on the balloon guide.
Always do that. To not do the anchor maneuver again for the next maneuver. So why it is so important to bring the catheter up to the skull base? Tobias will tell you.
And what you discussed here, that you really have to have a control over the balloon guide, underlines further that you need a little bit of experience of using it.
But I know that some of our colleague physicians say that with the balloon guide, you have this risk of making dissections, and that's exactly when you let it go up while you push. But I know with conventional guide catheters, we also see dissections. I don't think there's a big difference. It's something that we should look at also in these kind of trials. See we more dissections with balloon guide? I don't think so, but that impression is with many physicians.
Actually, in the two randomized trials, that was one point where they looked at, and even in the negative Chinese trial, it was equal.
It was equal. That's the proof. I think that's an impression that some have, but it's not the case probably.
Okay, so coming back to the data, why we think, well, we talked always that it's important to go upwards, but do we really have data to underline why we think this is important? And in the STRAIT data, we saw actually a quite significant drop in the reperfusion, at least in the first pass reperfusion rate, between the mid-segmental and the proximal placement. Of course, everything mediated by the anatomy. But this effect is not the first time that it was seen. So also in the ASSIST registry, they published a paper where they saw this already with a quite large effect. And the reason for this effect on outcome and reperfusion is probably that if you place the balloon in the high cervical segment, then the ICA is fixed in the petrous canal.
Yeah.
So if you then aspirate, you can really create backflow. If you create or you aspirate from a proximal position, then what you can see here in the video, the ICA will just collapse, and you create a lot of force at that position, and then all the debris and fragments will just stay upwards, distally of the balloon guiding catheter, and then if you open up again, then everything goes upwards. And I think this is the main reason.
Yeah, that's very well possible. I've seen a case once where a stent was in place already in the internal carotid artery, a wall stent, and they used a balloon guide, aspirated on it, and even the wall stent collapsed. So there's an enormous force when you aspirate, especially, well, if you do it very proximal, it's quite evident that the vessel will collapse then.
I think you only can prevent it if you create this effect, then you can just use it passively. You just open the valve and then it just runs passively through. But you have to think before reopening the balloon that you really need backflow before you reopen. And sometimes it's not possible. And then
no. So we have a good explanation. We have evidence now from your STRAIT registry that placing it more distal leads to better outcomes. So I think that's a very important message. If you use a balloon guide, place it distally, and that's possible now with the newer generation.
Yeah, I think so. So then I think this is enough and evidence that I don't think we have to talk about that. I think in conclusion, or in a preliminary conclusion, we could say that the data that we have now further support that now having the newer generation devices, the results improved further.
Yeah.
And that the tip position really plays an important role. So if somebody is thinking about doing another trial, which I think will become necessary, all these aspects I think should be considered beforehand in the planning phase. But I think these are not the only reasons to use a balloon guiding catheters.
No, you look of course at the prevention of distal emboli and then finally the outcome, but technically, and you showed already in that case that it can help you passing difficult anatomy. And I think that's what your last sentence. You can use it in many ways, and we have seen examples of that, how it can be helpful in other situations, and you have more examples I heard with other ways of using the balloon guide or other, I wouldn't say indications, but reason that it can be helpful.
So maybe another scenario, we also have evidence for using it in cases of tandem occlusions, where we have to stent the ICA. It's of course emboli protection, but also the studies show that we have a shorter procedure time, we have more success for recanalization, and we have a better outcome when using the balloon guiding catheter for tandem occlusions. Well, what we do always when you do elective stenting, we always use the balloon guiding catheter during the navigation, during the PTA, and during the stent placement, and have backflow on the balloon guiding or aspirate on that to prevent the emboli.
So also in elective cases of carotid stenting, nowadays you use a balloon guide?
Always.
Always, yeah.
So here's a case for that. It was a patient with a post-radiogenic stenosis in the ICA. This are the arterial access pictures where you can imagine it's not easy to go there. The external hospital tried it and failed because they did not have the balloon guiding catheter. So the patient came to us, and what we did, we used the balloon guiding first to generate stability. In the middle picture you see we inflated the balloon and then had it as an anchor for stability to get the PTA balloon up there through the tortuous vessels. And then we inflate the PTA balloon, deflate the balloon guiding balloon, and then we can move it up. Yeah, it was a technique that worked to bring the balloon guiding in the common carotid artery direct directly
This is again difficult anatomy, how you can use it to overcome this difficult
to
anatomy.
come there. And then we have it at the right position to open the balloon and have the emboli protection during the stenting procedure.
Yeah.
So let's come to another case. It's a patient, we were contacted from the internal department. They wanted to place a central venous catheter in the jugular vein, but they punctured the common carotid artery. And what happened, a big hematoma that expanded into the mediastinum, and we had a pseudoaneurysm, a big aneurysm that also has thrombus in the aneurysmal sac. And then they said, okay, what can you do? And first we thought, okay, placing a stent graft, but that was not possible because of the underlying hematological disease of the patient. He should not become antiplatelets. So we decided, okay, then we try coiling of the aneurysm. And then we decided to use a balloon guiding again to bring it in the common carotid artery to have, again, the ambulatory protection, because when we insert the coils, there's so much ambulous material that we feared to mobilize that and did not want to generate a stroke
So
in this
did you
procedure.
aspirate through the balloon at that time for this occasion, or just passively place the balloon and
We always open the back valve and then leave the, allow
so
backflow,
passively,
that all the fragments we possibly mobilize go back. Because
But
of
you
the
do not
pressure.
actively aspirate during this coiling
No,
procedure.
it should come to, there's too much blood that comes
Yeah.
back. So that was the
It takes
result.
time, actually.
It takes time. That was the result of that coiling.
Yeah.
So let's come to the last case. We had a young lady that came with an intracranial MT occlusion due to this dissection of the ACI. You can see here the typical sign. And as you know, it's sometimes not so easy to reach the true lumen when you want to navigate to come up. So I can show you one trick. It's from, thanks to Jan Graller from Bern for the nice drawings. As you can see here, the dissection membrane hinders the way to go into the true lumen, and then you use a balloon guiding catheter. You inflate the balloon, get backflow, and then the membrane will dislocate, and then you have the right way to find into the true lumen. And what you also can do, you have a second access into the contralateral artery, then you make a series, and then you can visualize your way that you have to navigate and find on the right side here, the right way into the true lumen. That is very helpful in such cases where it's not possible.
It's nice to visualize it like this. It's a very nice maneuver. I've done it once, but it works. So if you can't enter the true lumen, you inflate the balloon, aspirate, and then suddenly there's a lot of space. Then it goes up easily.
It's quick, and you don't have so much complications while navigating into the
for the
dissection.
interventionists who are not familiar with this maneuver, I think it is very helpful in difficult situations of dissection. Yeah.
So after navigating, we brought up the balloon guiding catheter to the right position at the skull base. We made the recanalization of the MT occlusion. It worked very well, but there was a distal occlusion, maybe an embolus. And it was a young lady, so we said, okay, let's go for that too. And as you can imagine what happened, we perforated the vessel, and then what can you do? The quickest thing you can do is inflate the balloon. You have it on board, you have it at the skull base, you can inflate it and reduce the inflow pressure. And that, with that you gain time for all the other things you have to do when you have a perforation for temporary or permanent coiling procedure, for example. So that's a good safety.
No, I think this is a very important aspect of the balloon guide as well, and we discussed that in our team as well. As soon as you have a perforation, the fastest thing you can do is just inflate the balloon, and you lower the pressure already, and then you have more time to think how you solve this problem of a perforation. If you don't have a balloon guide, you want to act fast, use a temporary coil or use a Neuro balloon, but that takes time. Or press. That's true, you can press the carotid, that's another thing. But this is so easy, it goes very fast. So yes, it's a very nice example how you can use a balloon guide to help you in these complication situations. Yeah, I think we have seen now, of course, the aim of a balloon guide to prevent distal emboli. We have yeah, we have evidence. We had already evidence from the past with the older generation balloon guides, but now you showed clearly that if you place it more distally, you have much better effect of the balloon guide, and that is possible with the newer generation. So I think even for those physicians that thought over the past years, well, what is the additional value of a balloon guide? I can do just as well with a normal guide catheter. That was probably because it was more difficult to get a balloon guide up, so they struggled to get it up. Now with the newer generation, I think they will see that if they use that one, it is just as easy as a normal guide catheter, but you have the advantage of a balloon guide, not only to prevent distal emboli, but also in other situations, like when you have a perforation, like when you have difficult anatomy. I think there are many, many ways that you will find your benefit of using a balloon guide. And the last thing, preparing a balloon guide, it takes you a few seconds, and you can do that while someone else is doing the puncture or whatever, or you do the puncture and your technician prepares the balloon. I don't think that that's a reason not to use it, that you don't delay the procedure. No, thank you very much. They were very nice cases, and I think the evidence, you said we need a new randomized trial. Are you thinking about it, to do it, or?
Yes, I am, but, or we are, but, well, it's difficult because we need a lot of money for that.
Yeah.
So
Okay.
But
We discussed that afterwards.
Yes,
but I think that would be nice. Because,
yes,
again, with those two trials, we do not change the evidence that is currently in the guidelines. So I think we need stronger evidence, and with the newer generation, I think we can get the evidence that it works better. Okay, I think we're at the end of this nice session. Thank you very much again for showing the cases, for showing the results of the STRAIT and the other studies. And I hope that the audience has learned something from it. I don't know if we have convinced them to use it, but maybe we helped them a bit in seeing what the benefits are of using a balloon guide. Thank you very much. Thank you.
thank you.